Hello everyone. Welcome back to the series of lectures in endocrinology. Till now, we were discussing about the disorders of thyroid, where we have discussed about hypothyroidism. Now we will be moving on to hyperthyroidism. So let us understand the first difference between these two terms, which is your thyrotoxicosis and your hyperthyroidism. So what is the difference between thyrotoxicosis and hyperthyroidism? So thyrotoxicosis basically refers to the state of thyroid hormone excess. It is the state of thyroid hormone excess where the thyroid gland is not hyperfunctioning. It is not hyperfunctioning. Okay? Hyperthyroidism means what? Hyperthyroidism means that the thyroid gland is functioning. Thyroid gland is hyperfunctioning. Okay, so the thyroid gland is hyperfunctioning and there is increased TSH. Okay, so both have increased TSH. In thyrotoxicosis, the thyroid gland is not hyperfunctioning. TSH can be from the gland, TSH can be from elsewhere as well, like ectopic TSH production in struma, overi. Hyperthyroidism means that the thyroid gland is functioning. It is hyperfunctioning. Okay, fine. Now let us look at the etiologies. So primary hyperthyroidism means what? The thyroid gland is hyperfunctioning in primary hyperthyroidism. Secondary hyperthyroidism means the etiology is somewhere from the pituitary. The etiology is somewhere from the pituitary. Then you have thyrotoxicosis without hyperthyroidism, which means that there is a state of thyroid hormone excess, but it is not because the gland is hyperfunctioning. Okay, this is the most important differences. Now let us look at the causes for primary hyperthyroidism. So most importantly, we have Graves disease. So Graves disease is an autoimmune disorder where there is excessive production of TSH. Fine. Then you have toxic multinodular goiter and toxic adenoma, which means that these are benign tumors of the thyroid gland or benign nodules which are there in the thyroid gland which can by themselves produce TSH. Then functioning thyroid CA or metastasis. Activating mutations of the TSH receptor, activating mutation of the GS alpha mutation which is seen in your McCune-Albright syndrome. Then drugs, iodine excess. We had learnt of this phenomenon called Wolff-Chaikoff effect where iodine excess can cause thyroid hormone deficiency. Here iodine excess is causing hyperthyroidism and this is what we call as Jod-Basedow phenomenon. So when the iodine excess is causing thyroid hormone excess or hyperthyroidism, it is called as Jod-Basedow phenomenon. Okay. So what are the causes for primary hyperthyroidism? We have Graves disease, toxic MNG, toxic adenoma, then genetic causes because of activating mutation of TSH receptor and Jod-Basedow phenomenon. Let us look at thyrotoxicosis without hyperthyroidism. So this happens when the TSH is elevated but the thyroid gland is not hyperfunctioning. Subacute thyroiditis, silent thyroiditis, destruction of the thyroid gland like amiodarone radiation. So what happens is that thyroid hormone will be stored within the follicles, right? So the TSH production has not increased but the thyroid hormone is stored within the follicles. So whenever there is a destruction to the gland or inflammation of the gland like in thyroiditis or destruction because of drugs like amiodarone, the stored thyroid is released. So the stored thyroid hormone, stored TSH is released. Right? That's why it results in thyrotoxicosis, not because the gland is producing more. Okay? Then ingestion of excess thyroid hormone can also result in your thyrotoxicosis. So this is about your thyrotoxicosis. Okay? Secondary hyperthyroidism can be due to any problems with the pituitary, which we had already learnt in our class on hypopituitarism, like a TSH secreting pituitary adenoma, chronic gonadotropin secreting tumors, and gestational thyrotoxicosis. Okay, so these are all examples of secondary hyperthyroidism or causes because of which TSH is produced from ectopic sites. Okay, fine. So this is about the various etiologies for hyperthyroidism and what is the difference between hyperthyroidism and thyrotoxicosis. Now let us move on to the most important of the diseases, which is your Graves disease. So most important of the diseases associated with hyperthyroidism is your Graves disease. So what is the age group at which Graves disease is common? it is seen in the age group of 20 to 50 years. Right? So what is the pathogenesis? Most often it has genetic associations like CTLA4, CD25, PTPN22, CD226, FCRL3 and so on. So these are some of the genes which are associated with Graves' disease. Apart from that, there can be environmental factors like smoking, iodine intake, heart is your highly active antiretroviral therapy, use of immune checkpoint inhibitors, which is the new vogue in your cancer treatment. So all of these risk factors are present, and what happens is that there is a TSH stimulating antibodies which are produced. So there are TSH stimulating antibodies which are produced. So in 80% of the patient it is a TSH receptor antibody or your TRAB. In 80% of the patients it's your TSH receptor antibody or your TRAB. In 50% of the patients you can also find anti-TPO. So what happens is that finally there are TSH stimulation, the TSH receptor is stimulated and there is excessive production of TSH. TSH receptor is stimulated and there is excessive production of TSH. Okay. So this is your basic pathogenesis of Graves' disease. Fine. Okay. Another very important point is that in your Graves' disease you can have an associated condition which is called as Graves' ophthalmopathy. Graves' ophthalmopathy. So the most sinister and the most difficult to treat association of Graves' disease is your Graves' ophthalmopathy, where you can have involvement of your eye and the orbit. You can have involvement of the eye and the orbit. Okay? Fine. Now let us look at the clinical features of hyperthyroidism one by one. So let us understand what are all the clinical features of hyperthyroidism. So this is in order of commonality. So the most common to the least common. So hyperactivity and irritability are the most common features of hyperthyroidism. So hyperactivity and irritability are the most common features. Then just opposite to hypothyroidism, you can have heat intolerance. There you have cold intolerance, here you have heat intolerance. Then we know that the thyroid hormone is responsible for maintaining the normal heart rate. If thyroid hormone is in excess, there is increased contractility. There is increased contractility. There is increase in the heart rate resulting in palpitations, and hyperthyroidism can also precipitate arrhythmias, most commonly atrial fibrillation. Atrial fibrillation. And because of this, thyroid hormone excess can cause increased metabolism. There can be increased metabolism and hence there is weight loss. There is weight loss. There can be diarrhea and oligomenorrhea. There can be menorrhagia in hypothyroidism and oligomenorrhea in hyperthyroidism. What are the signs? The resting heart rate itself will be higher. In hypo you have bradycardia, here you have tachycardia, you can have atrial fibrillation. Then you can have tremors, very importantly. Then goiter, there can be goiter as well. So you can find an enlargement of the thyroid gland in front of the trachea, which is your goiter. So goiter is not always seen only in hypothyroidism, it can be seen in hyper as well, because just now we had seen in the etiologies. Toxic multinodular goiter is an etiology for hyperthyroidism. Okay? Because of increased muscle breakdown, there is increased muscle breakdown. So you can have muscle weakness. And when this Graves' disease can involve the orbit, it can result in lid retraction and proptosis. So this is what results in a staring loop, lid retraction and proptosis. And sometimes it can be associated with gynecomastia as well. So these are about the most important symptoms and signs of hyperthyroidism. Okay. So this is showing what? This is showing your proptosis and lid retraction in your Graves' disease. Okay. 1% of the individuals can be associated with these kind of skin changes, and this is what we call as your thyroid dermopathy. Okay, so this type of skin changes which are seen is thyroid dermopathy. So what are the characteristic features of this? There is a skin edema. There is a skin edema. There can be hyperpigmentation. There can be hyperpigmentation and there can be skin thickening as well. There can be skin thickening as well. And this entire changes also have a name. They also have a name, and this is called as pretibial myxedema. Pretibial myxedema. So remember, very importantly, myxedema is a term which is associated with hypothyroidism. But this thyroid dermopathy or the skin changes which you find in hyperthyroidism is called as pretibial myxedema, because most commonly it is found in the region of the tibia. Next, can you see here that what are you seeing? There is bulbous enlargements of the distal ends of the phalanx. So what is this? This is nothing but clubbing. So the clubbing which is seen in hyperthyroidism is called as thyroid acropathy. Thyroid acropathy. So thyroid acropathy is also another association which is seen in less than 1% of these individuals. Okay. So we have learnt about pretibial myxedema, ophthalmopathy, we have learnt about thyroid acropathy, and we have learnt about the various clinical symptoms and signs of hyperthyroidism. Now let us understand the Graves ophthalmopathy. In Graves ophthalmopathy, what is the earliest sign? What is the earliest sign? The earliest sign is a sign of grittiness in the eye. There is grittiness in the eye. Okay, you find a sign of grittiness, a sensation of dryness, grittiness in the eye or foreign body-like sensation. So, followed by grittiness of the eye, we have another classification which is called as your nose specs classification. So, we have another classification called as a nose specs classification to grade your Graves ophthalmopathy. So, according to this, what is N? N refers to no signs, only symptoms. No signs, only symptoms. So, they may have grittiness of the eye, or they may have watering of the eye, they may have some mild problem, but you do not have any major signs, right? So, they may have grittiness, they may have some pain, they may have some dryness. Then O. O basically refers to only signs, no symptoms. The symptoms may or may not be there. So, only signs means what? You find lid lag, you find staring look, you can find proptosis. Okay. So, there are only signs but there are no symptoms. Then S. S basically refers to the stage where there is soft tissue involvement with signs and symptoms. There is soft tissue involvement with signs and symptoms, which means you can have periorbital edema. Then P basically means that there is proptosis has definitely set in with a proptosis means what? Your eyeball is pushed out more than 22 mm. Proptosis more than 22 mm. Then E basically refers to the extraocular muscle involvement. The most common muscle is your inferior rectus, right? So, finally, if there is extraocular muscle involvement, then they will have restriction of movement and it can result in ophthalmoplegia. C refers to corneal involvement. And finally, you can have sight loss. Okay. So, this is your nose specs classification for your Graves disease, for staging of the severity of Graves disease as well. Okay. So, initially you do not have signs, you may have symptoms. Then you can have only symptoms, but you can have only signs but no symptoms. Then you have proptosis, then you have soft tissue involvement, proptosis, then you have extraocular muscle involvement, corneal involvement, and finally sight loss. So, let us understand how do you diagnose and how do you treat your hyperthyroidism. So, what will be the lab findings? So, if it is a primary hyperthyroidism like your Graves disease, then TSH will be low, FT3, FT4 will be elevated. What are the antibodies you will look for? The antibodies is basically your TRAB antibodies and anti-TPO. Okay, fine. Then ultrasound can show evidence of hyperthyroidism. In the ultrasound, what happens is that when you take an ultrasound, there will be increased vascularity. Right? So, there will be increased vascularity throughout the gland, and this is what we call as a pattern, which is called as the thyroid inferno. So when you do a Doppler study on the thyroid in a patient with hyperthyroidism, there is going to be increased vascularity in the gland, and that appearance is what we call as the thyroid inferno. Okay. Then radioactive iodine studies with your iodine 125. We had seen in your basic approach to thyroid function test chapter that in your radioactive iodine uptake there is increase and diffuse uptake. There is increased and diffuse uptake of the radioactive iodine, which is your iodine 125. Okay. So the approach to diagnosis of Graves disease will be, first you find out hyperthyroidism, then you do a thyroid ultrasound, or directly you do a radioactive iodine studies and do your antibodies. So in your radioactive iodine studies, you can find out whether this is Graves disease, is it a toxic MNG, is it an adenoma, or is it thyroiditis. Okay. How do we differentiate that? That we had just seen. What are the differential diagnoses for hyperthyroidism? The differential diagnosis is panic attack. Why? Because even hyperthyroidism, you can have palpitations, you can have sweating, you can have fear. This is seen in panic attack as well. Then pheochromocytoma. Pheochromocytoma can also present with episodes of sweating and palpitations, right? It can present with episodes of sweating and palpitations. So it mimics hyperthyroidism to a great extent. Okay, fine. So what is the course of Graves disease? So most of the patients have an relapsing remitting course. Most of the patients have a relapsing remitting course. Okay. So it is little bit of a prolonged treatment for the management of Graves disease. If there is Graves ophthalmopathy, depending upon the severity, you have to decide whether you want to give the medical management or whether you may have to do a surgical decompression, because sometimes if the Graves ophthalmopathy is very severe, then it can go and even damage the optic nerve, and that is life threatening, right? So in those cases, you will have to do a orbital decompression surgery. So the clinical course varies. It can be a relapsing remitting disease. Okay. So let us come to the treatment. Let us understand the management of Graves disease. So the first line treatment is the use of anti-thyroid drugs. The first line treatment in the management of Graves disease is the use of anti-thyroid drugs. So what are the two anti-thyroid drugs? It is your carbimazole or methimazole and your propylthiouracil or PTU. This is your carbimazole or methimazole and your PTU. Okay. So let us look at the salient differences between your carbimazole, methimazole and your PTU. So carbimazole is given at a dose of 10 to 20 mg q 8th hourly as an initial starting dose, and later on it can be reduced to an OD dose as well. Propylthiouracil is given at 100 to 200 mg 8th hour. Okay. Now, when do you prefer carbimazole? When do you prefer propylthiouracil? Remember that methimazole or carbimazole is associated with a condition which is called as carbimazole embryonopathy. Okay. So this is contraindicated in the initial or first trimester of pregnancy because it's associated with embryonopathy or teratogenic side effects, which is characterized by cutis aplasia, where there is a aplastic skin. That means the skin is not well developed. Apart from that, you can have GI symptoms like omphalocele, or you can have tracheoesophageal fistulas, right? So because of this risk of carbimazole embryonopathy, this is not given in the first trimester of pregnancy. Fine. Apart from this, whenever you are administering carbimazole to any patient, always be aware that there is an increased risk of neutropenia in these patients. Okay, so whenever your patient is on treatment with what we call as the brand name neomercazole, always look for your CBCs, do a regular monitoring of your CBCs, because if there is neutropenia, how is neutropenia heralded? Usually it is heralded by a small, insignificant but very significant sore throat. So if this patient develops a sore throat, remember there is a risk of neutropenia, and you immediately bring him to the hospital and you stop the drug. Okay, so very significant neutropenia can happen. Apart from that, it can also cause some amount of cholestasis. Okay, when we look at propylthiouracil with the side effect profile, this has a very high propensity to cause hepatotoxicity and acute liver failure. Okay, but it does not have this embryonic side effects. So PTU is given in the first trimester of pregnancy. first trimester of pregnancy. If the patient is having hyperthyroidism, give PTU. After that, you can switch to carbimazole because PTU you cannot continue for long because of its severe hepatotoxic side effects. Okay, fine. PTU is also associated with another very important syndrome called as Hirata syndrome or your anti-insulin antibody syndrome. Okay, so there are anti-insulin antibodies which is acquired, which is called as Hirata syndrome, associated with PTU therapy, and it can cause recurrent hypoglycemia. So, Hirata syndrome is associated with recurrent episodes of hypoglycemia which is of autoimmune nature, autoimmune hypoglycemia. Fine? Okay. So, this is about mainly or the most important points about your anti-thyroid drugs. Now, how do you monitor? So, once you have diagnosed the patient with Graves disease, started them on anti-thyroid drugs, you monitor them every 6 to 8 weeks. And what will you monitor using? You monitor your FT3, FT4 levels. You do not monitor your TSH levels because the TSH can be suppressed for a very long time and it takes a long time to come back to normal. So, monitoring is done with your FT3, FT4 levels. So, if your FT3, FT4 were high, it has to come back to normal. Okay. And how long do you treat this patient, right? How long do you give this anti-thyroid therapy? It is not indefinite like your hypothyroidism. So, you give it for a period of around 18 months. You give it for a period of around 18 months to 2 years. Okay. And you see the response. If the patient is tolerating and for 18 months he is tolerated, TSH is within normal, you try to taper and stop the drug. But many times, like I said, Graves disease is a relapsing remitting disease. Okay, so there are chances of relapse, but anti-thyroid drugs have to be tapered and stopped within 18 months to 2 years. Fine? Okay. What is the next group of drugs? The next group of drugs that we use is not anything that targets the thyroid gland, but this helps in reducing the heart rate. Okay, this helps in reducing the heart rate. So, which group of drugs is that? That is your beta blockers, and you give your non-selective beta blockers like propranolol because there is a lot of anxiety, lot of palpitations associated with Graves disease which can be brought down, and it also improves the cardiac functioning. Many times Graves disease is associated with atrial fibrillation. So, if it's associated with atrial fibrillation, you may have to give beta blockers. Fine? Okay. Then, radioactive iodine therapy using iodine 131. Okay. So, what happens with this? This is your iodine 125. This is used for diagnosis where you see a diffuse uptake in the thyroid gland. Here we are talking about radioactive iodine therapy using iodine 131. So, this is basically a method of thyroid ablation. It helps in thyroid ablation. Okay. So, which group of patients do you want your radioactive iodine therapy to be done? So, you have to consider thyroid ablation using radioactive iodine 131 in patients whom there is no improvement or contraindication to use of anti-thyroid drugs. Right. So, after 2 years also there is no improvement, then refer the patient for radioactive iodine therapy. Okay. So, there is no improvement or contraindication to the use of anti-thyroid drugs, then you go ahead and do a radioactive iodine therapy. So, for this radioactive iodine therapy, all the anti-thyroid drugs have to be stopped for at least 3 to 7 days before your radioactive iodine therapy. Okay. Then, what are the safety precautions? Where is this radioiodine therapy contraindicated? It is most definitely contraindicated in pregnancy. It is contraindicated in pregnancy. So, pregnant women or those who are planning conception or young children are advised to stay away from patients who have undergone therapy as well up to a period of 1 week. Why? Because those patients who have undergone radioiodine therapy, there can be some radioactivity that is going on. So, not only that the pregnant patient should not undergo, there should not be contact with another patient who has undergone the therapy as well. Okay, so this is your safety precautions. Fine. This is your safety precautions that you have to take for radioiodine therapy. Now, after the administration of radioactive iodine therapy, if there is no improvement in the symptoms still, then you give a second dose after 6 months. So, after your first dose, no improvement, second dose is given after 6 months. Okay. Second dose is given after 6 months. Now, after this also there is no improvement, then you may have to consider surgery. You will have to consider surgical removal of the gland for Graves' disease. So, what are the contraindications? What are the contraindications? Contraindications is definitely pregnancy. Then, radioactive iodine therapy can cause worsening of Graves' ophthalmopathy. So, in Graves' ophthalmopathy, we do not give radioiodine therapy because it can cause worsening of your Graves' ophthalmopathy. Fine. After your radioactive iodine therapy, there can be some amount of transient hyperthyroidism and it takes time to settle down. Okay. So, this is about your radioiodine therapy using iodine 131. Fine. Okay. Now, let us understand in pregnancy, what do you want to do? In pregnancy, what do you want to do? We have just now seen what is it. We do not give carbimazole in the first trimester. So, we give PTU in the first trimester. After that, we switch over to carbimazole because of the risk of carbimazole embryonopathy. Also remember, whenever you give maternal antithyroid drugs, there is an increased risk of fetal hypothyroidism. So, you should be aware of that as well. Alright. So, we are discussing about the moderate to severe Graves' disease. So, in your moderate to severe Graves' disease, apart from your methylprednisolone and MMF, a newer drug which has come into the market is your teprotumumab. Okay, the newer drug which has come into the market is your teprotumumab. So, this teprotumumab is basically an anti-insulin-like growth factor 1 inhibitor or your insulin-like growth factor 1 receptor inhibitor. Okay. So, the main function of this teprotumumab is that this inhibits the actions of insulin-like growth factor 1, which is basically involved in your fibrosis and swelling of the orbital glands. Okay. So, this is your teprotumumab. Finally, the only option in the management of Graves' disease apart from medical management is your surgery. So, in this, if the Graves' disease is not responding to any of this, then you do a subtotal or a subtotal thyroidectomy is performed. Okay. Now we move on to what is your thyroid storm. So, thyroid storm is basically a medical emergency. It is basically a medical emergency which is characterized by high thyrotoxicosis. There is thyrotoxicosis and there is excessive production of thyroid hormones and there is a thyroid storm. So, how does this patient present? Patient presents with fever. In fact, the patient presents with hyperthermia. The patient presents with delirium, coma, seizures and hyperthermia. Okay, so this is your thyroid storm. What is it precipitated by? It is precipitated by, similar to your myxedema coma, it is precipitated by infection, it is precipitated by sepsis, right? It can be precipitated by dehydration. So, any of it can precipitate your thyroid storm. Alright. Also, what are they at risk of? Since there is so much of hyperthyroidism, they are at a risk of congestive cardiac failure, they are at a risk of arrhythmias as well. They are at a risk of congestive cardiac failure and at a risk of arrhythmias as well. Fine? Okay. So, how do you manage this thyroid storm? So, you have to start with antithyroid treatment. So, large doses of propyl thiouracil at a dose of around 500 to 1000 mg loading dose and 250 mg Q4 hourly is the first drug that we use. And what is the mechanism of action? The peripheral conversion of T4 to T3 is inhibited and it also acts as it inhibits your production of thyroid hormones as well. Then, saturated solution of potassium iodide, SSKI is saturated solution of potassium iodide and this is given 5 drops Q6 hourly. So, this is given as an oral solution, 5 drops Q6 hourly. How does the saturated solution of potassium iodide work? This works using your Wolff-Chaikoff effect. This causes Wolff-Chaikoff effect where excess iodine intake can cause iodine deficiency. So, you give iodine. Then propranolol is given, which is your beta blocker, 80 mg Q4 hourly. So, this is given orally or sometimes you can give it IV as well. The dose is different. and this is also going to help in inhibiting the peripheral conversion of T4 to T3. Alright, then there is a role of glucocorticoids. You give hydrocortisone, and many a times your thyroid storm is precipitated by infection, give them antibiotics. Lastly, there is evidence of cholestyramine, because cholestyramine can sequester the thyroid hormones. So, cholestyramine can also be tried. Now, apart from all this, you definitely have to take care of the other measures. So, you will have to take care of cooling, because there is hyperthermia. You have to do cooling. Okay, so you will have to do external cooling has to be done. Give them IV fluids, make sure that they are volume depleted. Okay. And you take care of your electrolytes, you take care of your glucose, you take care of the nutrition till they come out of this crisis. So, this is about the thyroid storm. So, with this we have come to the end of our discussion on hyperthyroidism and Graves disease. So, we had looked at hyperthyroidism, the causes of hyperthyroidism, differences between hyperthyroidism, thyrotoxicosis. We had learnt about Graves disease, Graves ophthalmopathy and thyroid storm. Thank you.